like to introduce Rachel, Marek, and Deborah Colina. Rachel currently is the director of our inpatient pediatric hospitalist program at Santa Rosa Memorial Hospital. She was raised in Santa Rosa, in fact, attended the JC, then went to medical school at Davis. She went to undergraduate at Davis, got her medical school at the University of Michigan, and then did her pediatric training at Children's Hospital in Los Angeles. Deb Colina, after graduating from Stanford, and I think having an intervening life, right? Then went to UCSF Medical School, trained at Michigan State at their Level 1 Trauma Center, and she's now one of my partners in the emergency department at Memorial, and on her own has represented us on a volunteer basis to be the liaison for the pediatric service between the emergency department and the inpatient pediatric hospital service. I think they have planned 5, right? 5 sort of TED Talks about 5 different pediatric conditions, short, sweet, and we'll leave a little short time for answers and questions at the end. Thank you.
So thank you all for having us here today. Deb, Colina, and I are very excited, come on up, to be here and to get the opportunity to talk to you. We're gonna call it an opportunity and not a challenge to be the ones talking to you after lunch. We know this is the time, at least for me, where I'd wanna take a nap. So we hope to keep you mildly to moderately entertained. We know how much Tuck likes us since he put us right after lunch, but we are looking forward to keeping you guys engaged and interested, even if pediatrics isn't in the patient population that you typically take care of. So I wanted to take just 2 minutes at the beginning to talk about pediatrics at Santa Rosa Memorial Hospital. We are the last 24/7 inpatient pediatric hospitalist service north to the border with Oregon. So then when they're talking this morning about the 8,000 square miles that we cover, we are definitely a part of that. We get patients in from all over Sonoma County, Mendocino County, Lake County, and we welcome any transfers, questions, consults, anything y'all might have via the transfer center. We love hearing from you from your offices or your urgent cares. We like to try to avoid the emergency department, though we love our colleagues down there, if at all possible. We do not have a PICU, but we have a UCSF neonatal intensive care unit. We also, most recently, we have a joint venture with UCSF for our Women's and Children's Service Line, which is something that just came up in the last 2 months. So we're really excited about that and really excited about those opportunities going forward. This is perhaps too small to see, but hopefully it just gives you a sense of the range of diagnoses that we accept. It doesn't include every diagnosis that we see on pediatrics, but just gives you a sense of all the various things that we do see, from the very, very little children, from kids that are just a couple of days old, up to our teenagers. So we welcome any consults, questions through our transfer center. We do have a 12-room, 22-bed pediatrics ward, staffed 24/7 by us. We have great pediatric nurses. We cannot work without our fantastic nursing staff and respiratory therapy care staff as well. We encourage parents to room in with their child when they're in the hospital, and in general, they will have a private room, which is really nice. All of us don't have an office. We just work in the hospital. So this is our specialty. This is what we do. We don't get pulled away. We are there to round on the child several times throughout the day. We're there to deal with emergencies and answer questions. We really hope this helps improve patient experience in the hospital for the entire family. It's not just about the child, but it's about that entire family. And we also hope this leads to a decreased length of stay overall. We really appreciate all the primary care doctors who are out here in the audience today. We know we cannot do our job without the excellent work that y'all are doing out in the community, taking care of these kids and mostly keeping them out of the hospital, but we really are so appreciative of that, and we really try to make that transition as smooth as possible from the hospital to the child's medical home at discharge. So Dr. Colina and I today are going to talk about some topics in pediatrics which are fairly general interest, which can happen anywhere. They can happen in your office, they can happen you can see them in the urgent care, you can see them in the ER with these diagnoses, but we're hoping that we could just hit home a few clinical vignettes. They are pint-sized, as Tuck said, but children are not little adults, and that's one of pediatrics our big sayings, and we would like to just go over these. So our case 1 is the barking seal cough. This child is not any of these seals down below. She is a different seal entirely. She is a 14-month-old child who's seen in the urgent care. She had 3 days of dry cough, and she's had also fever up to 102 degrees Fahrenheit. She otherwise has been doing pretty well. She's been tolerating oral intake, she's been playful, except when she's febrile, and the parents are concerned about the noise she is making and about her fast breathing too. So otherwise, she's pretty healthy. Of note, her immunizations are up to date, including the flu vaccine. Her dad was recently sick with laryngitis. There's definitely a sick contact in the family. So you see this kid in your urgent care, and you notice a kid that's got a low-grade temp. She's breathing a little bit fast, and she's got some moderate respiratory distress as well. She's tachypnic. She has some subcostal and supraclavicular retractions. She has a hoarse voice. She's talking in single words, but very developmentally appropriate for this child. And you note some stridor at rest, some coarse breath sounds when you auscultate her lungs, with some transmitted upper airway sounds in stridor. So she's a little tachycardic, but otherwise her exam was pretty unremarkable. So what's going on? What do we think is happening here? Probably the top 5 things on my differential, just like on your differential, are probably croup, 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 and croup. We'll give 1 point for every letter in that. But there certainly are a lot of other disease processes that can cause stridor in children. So it's just important to realize that not every child that has stridor, not every barking cough is croup. And so you want to keep in mind your bacterial tracheitis. Epiglottitis is something that we simply do not see anymore for all intents and purposes. I've never seen it all through residency. We used to look for a child with epiglottitis. Vaccines have worked despite what people in the West County think. This essentially is the great success of our vaccines. H.I.V has essentially eliminated that disease process. There's obviously several other things on this differential. You really want to think about alternative diagnoses if you have a child that's quite small, less than 6 months of age, or over 6 years. It's not to say that it can't be croup, it's just that you want to just think about other things as well. And typically croup is a self-limited illness. It lasts about 3 to 5 days. So if you have a child that's had stridor for more than 4 days, or cough for greater than 10 days, you want to really be thinking again on that differential diagnosis about something else. Certainly kids with recurrent croup within a month, you want to think maybe about more airway things. Also consider maybe a foreign body aspiration. In addition, kids with non-elective intubations in the last month, or somebody who has had a prolonged intubation, may have structural anatomic problems that may be the reason why they're making this sound and you're hearing them in your urgent care. A kid that looks toxic. These kids usually look pretty well, but a truly toxic looking kid, you really want to make sure you're thinking about other things in your differential. A kid that's drooling, having difficulty swallowing, severe anxiety, also kids that you'd be very worried about. And this is an upper airway disease, so hypoxia or cyanosis would be very uncommon in croup, and certainly a very worrisome sign. Kids with skin hemangiomas can also have airway hemangiomas. That's just something to recognize on your physical exam if that's something that you're seeing. So croup is also known as laryngotracheobronchitis, but we don't like to say that 1,000 times over, and we certainly can't expect our parents to be able to say that, so we call it croup. It is a viral illness, most commonly caused by parainfluenza virus, and it leads to inflammation of the upper airway, typically that barking cough, the hoarse voice, and symptoms are typically worse at night, which is why you guys get these kids in your ER at 3 o'clock in the morning, or if you're a primary care physician, you get the phone call at 2 a.m. about this kid who's breathing funny at home and making this funny noise. I work as part of the UCSF Pediatric Hospitalist Collaborative, and as part of that collaborative, we put together a croup algorithm or guidelines. I know that maybe it's kind of small to see from here, but I at least wanted to have you guys go home with something that you could potentially use and utilize in your urgent care or your emergency department to help you with the management of croup. And essentially, we divided these children into mild, moderate, and severe symptoms. So a child with mild croup has no stridor at rest, that looks really comfortable, and for that child, we would recommend just a single dose of oral dexamethasone. And we'll talk a little bit more about how we chose dexamethasone and the dosage and all that stuff in just a minute. But if you saw a kid with very mild croup in your office, maybe just has a history of some barking cough at home but looks great, if you guys chose not to do any steroids, I think that's absolutely fine as well. But this is really intended for the child who's going to the urgent care or the ER with croup. So a child with moderate croup, and this is probably our kid in our vignette today, has stridor at rest, which she did. She's tachypnic, moderate work of breathing, some anxiety or agitation, and difficulty talking or feeding. So this, again, you want to give that single dose of dexamethasone. They just need 1 dose. They don't need any more steroids beyond that because it's a self-limited course. And you want to consider giving them a dose of racemic epinephrine, which you can repeat up to every 20 minutes. And then a kid that's really in severe distress, and these are your kids that have, again, stridor at rest, but also severe work of breathing. They may actually have respiratory fatigue, which is much more concerning. They may have cyanosis or hypoxia, again, much more concerning overall. starting again with your dexamethasone and your racemic epinephrine. And then these are kids whose airway, if you're going to need an advanced airway, is going to be more difficult than your typical airway. So you want to make sure you get your personnel in place. You want to make sure you're calling the anesthesia or ENT or whomever your resources might be in your hospital, potentially help with that intubation. You really also, if that's a child that ends up needing to be intubated, you really want to make sure you have different tubes of various sizes, because they may need a size or two down from what they Broslow out at. And talking to the UCSF PICU and talking to the emergency room physicians there, they were saying too that they would really consider not paralyzing these kids if you end up having to intubate them, because it can be very hard to bag through a child with croup who's paralyzed, who you can't get the airway. So our mainstay of treatment, as you've noticed from all of our slides, is dexamethasone. You can use it orally, you can use it IM, you can use it IV. Overall, the literature prefers the PO route. Actually, it's been shown to have a faster time to symptom resolution. So although it seems like maybe the IM or the IV might be better, PO actually is. And to get the PO dexamethasone in, there is a liquid formulation of oral dexamethasone. We don't recommend that for anybody. It's not very concentrated. The kids have to take huge volumes of it and they'll never choke it down. So we recommended at Memorial, what we typically do is give the IV form PO, which is a very small volume. It doesn't taste that great, but they can take it down with some apple juice, or you can crush the tabs. So the dose, at the UCSF Collaborative, we decided on the 0.6 milligrams per kilogram per dose. So what literature is this based on? And we know that other people have different dosing ranges, and there certainly is a range. Well, the reality is, looking at all the literature, there's never been any head-to-head studies looking at different dosing of dexamethasone. When they've compared dexamethasone, they've compared dexamethasone to nothing. We know dexamethasone works. We know steroids works. We've never done any studies to look at the different dosing ranges, but typically, most hospitals are still using the 0.6 mg per kg per dose and maxing out at 16 milligrams. And there is some alternative data, and this might be helpful for you guys in a family maybe that's resistant to getting systemic steroids, or in a child that has really severe respiratory distress and you feel like they're not going to tolerate PO medications, and you're worried that by poking them that might make their distress even worse. There is some limited evidence to suggest that budesonide or nebulized Pulmicort actually has a really good effect as well. In the studies they use 2 to 4 milligrams, which is actually quite a bit bigger than the Respule, so you're going to need to use several Respules to get to that dosing range. So what are things that maybe we used to do and we don't do anymore? We don't need to do any x-rays. There's no need for a child with typical croup to get any x-rays, neither neck films nor chest x-rays. There's no need for lab studies. Antibiotics, it's a viral illness. There's no need for those. In general, you don't need continuous pulse oximetry reading. Decongestants or antitussive medications are not needed. And cool mist is not recommended in the hospital, although still a humidifier at home with a cool night air is still good discharge advice. So when do they get to go home? Well, if they have no or minimal stridor at rest, they're breathing comfortably, that's a child that can go home. They're able to feed and talk. They're able to maintain adequate hydration. And you really want to make sure it's been at least 2 hours since their last racemic epinephrine treatment. And I don't know when you all trained or when you heard this, but I remember when I was in training, they always talked about this rebound effect of racemic epinephrine. In 4 hours, 6 hours, 8 hours, you choose your hours. Everybody told you different hours. And they would say, these kids are going to get worse acutely, and you're going to send them home, and they're going to decompensate. It just doesn't happen. Racemic epinephrine has its peak effect about 30 minutes after it's given, and by 2 hours, the effects of racemic epinephrine have entirely dissipated. So you're completely safe and fine sending these kids home at the 2-hour mark, and this was shown in a big Cochrane review from 2011. And if you have a kid in the ER that needs several racemic epinephrine treatments, and we use sort of 3 or more as our guideline, that's a kid that you might really want to think about giving us a call through the transfer center, or giving your local pediatricians a call, or at least observing in your ER for a longer period of time, because this is a kid that might have some more respiratory distress. So what's the resolution? These sparking seals, they all get better and get to go home with their moms.
Okay, thank you, Dr. Marek. Next case is, I call the wheezer. So my patient's a 3-year-old who presents with wheezing and difficulty breathing and coughing for at least 2 weeks. It's worse at night. Mom's been using decongestants, antihistamines, and leftover albuterol syrup. But today, initially she thought the child was getting better, but today she became acutely worse, so mom became frightened, called 911, and came into the emergency department. Past medical history is significant for eczema as well as asthma. She's never had to be intubated or hospitalized because of asthma. She usually is just seen in the ED and then discharged. Home meds include albuterol, metered dose inhaler, no known allergies, immunizations are up to date. The child lives with her parents, siblings, and a dog. Dad smokes outside. And the recent family history is that there's siblings at home with URI-like symptoms. So our presentation, her temp is 38.1, pulse 150, respiratory rate of 40, blood pressure 85/65. In general, she's alert, in moderate respiratory distress, and she's tripoding. She has dry mucous membranes, tachypnic with end expiratory wheezes, retractions, nasal flaring. She's tachycardic, but no murmurs, rubs, or gallops, and her extremities are pink, warm, and dry. So what is asthma? So in a nutshell, it's swelling of the bronchioles leading to bronchial constriction and spasm. There's increased secretion production, which leads to increased airway resistance and air trapping, hypoxia. And it's most common in children over 2 years old. So right here down, this lower picture depicts normal bronchiole. Here we have an inflamed bronchiole where you have swelling of the endothelium, the bronchial endothelium, increased secretions, which leads to a decrease in the lumen diameter, and outflow and inflow, air trapping, and increased airway resistance. So the signs and symptoms of asthma actually are on a continuum from, as you know, mild, moderate, and severe. The more severe signs would be tripoding position with accessory muscle use, audible wheezes with prolonged expiratory phase, increased work of breathing, retractions, and finally, when you get into more serious cases, the children start to exhibit anxiety, agitation, and finally, they fatigue. And that's an ominous sign where exhaustion can set in and ultimately respiratory failure. So in the ED, as in the office, I'm sure you need to make a quick assessment of your patient. So quick history and physical, determine in your mind mild, moderate, severe, or respiratory failure. In the ED, we place them on a cardiac monitor, and we apply supplemental oxygen, and if in severe cases, we'll also get a blood pressure. So this is a very busy slide, and I'm going to break this down the next 4 slides. But this is based on the Northern California Pediatric Hospital Medicine Consortium that Dr. Marek's a part of. And they came up with guidelines for, after reviewing the literature, for recommendations for treatment for mild, moderate, and severe, as well as impending respiratory failure. So mild cases, you can give them an albuterol neb, give them a few albuterol puffer, send them home with close follow-up, 1 or 2 days. You can decide whether you want to add in steroids, prednisolone, or dexamethasone. This, in children less than 8 years old, they recommend discharging with a mask. They're older than 8 years old, they can use the metered dose, the inhalers. So once we start getting into more moderate exacerbations, in the ED, we recommend doing a duoneb, 3 duonebs back to back. Follow that with an albuterol 1 hour-long nebulized treatment. And look at the dose, 10 to 15 milligrams per hour. So we use high dose, even in moderate exacerbations. We back that up with dexamethasone or prednisolone. And at that point, we start considering admission. Now, as it progresses to a more, if you can't get it under control and now you're dealing with a more severe case, you consider magnesium. So in severe cases, I like to call my respiratory therapist, get extra hands, more nurses, get IV, place them on the monitor, add supplemental oxygen, start duonebs, followed by the hour-long albuterol nebs, and then start my steroids, and since I have an IV, I can start Solumedrol. And then if I still feel like the child is in trouble, I'll order magnesium, 40 to 50 mg per kg bolus, and then also normal saline to replace insensible losses. And then close monitoring every 15 minutes. I start calling my hospitalist to either come down and help me transfer. Oops. So the bottom line with impending respiratory failure, what I want everyone in the room to take home is that the last thing I want to do is intubate this patient. It just leads to more problems. So I treat them medically do everything I did that I would do in the mild, moderate cases, and then I consider adding on epinephrine and tributaline, because I want to avoid that intubation. So bottom line, asthma treatment in the ED escalates as your case, the severity escalates, of course. Apply supplemental oxygen, use your DuoNebs, 3 DuoNebs, followed by an hour-long high-dose albuterol neb. Add in magnesium, epinephrine, tributaline if you need it. Get all your ducks in a row, call RT, start mobilizing your hospitalist or transfer. Avoid intubation.
So our next case is the fever and cough that will not stop, and it's a case that you guys have all seen. In this particular case, this is a 3-year-old who presents to the emergency department. He's had 9 days of cough and rhinorrhea. He's had fever, though, just for up to 103 for just the last 3 days. And this is actually an interesting part of the history, where he's been sick for about a week before he develops the fever. He's had some decreased oral intake for the last couple of days as well, with decreased urine output. There's multiple sick contacts at home, but everybody else got better several days ago. So this kid's otherwise overall pretty healthy. He's had some otitis medias in the past. He's an X34-weeker, but had a really unremarkable NICU course. His immunizations as well are up to date. He does have a couple of siblings with asthma, and mom has eczema, but he himself has never had any wheeze-associated respiratory illnesses in the past. On your physical exam, when you see this kid, this is a kid that worries you almost immediately when you walk in the room. I know Dr. Colina and I both seen kids like this before, where you go in the room and you think, oh, this kid does not look well. So he has a temp of almost 103 in your emergency department. Again, he's 3 years old. His respiratory rate is 56, so he's quite tachypnic. He's tachycardic at 162, and his SATs are only 86% on room air. Happily, your nursing staff is excellent, so they've already slapped 2 liters of nasal cannula on this kiddo, and he's 93% on that. But he's in moderate respiratory distress with some moderate subcostal retractions. He has fairly tacky mucous membranes. You actually don't hear any wheezes or rhonchi or rales, which is quite common. You actually just hear decreased breath sounds in the right lower to mid lung field. So it's really important to be comparing those lung fields, especially in kids, so they can hide these subsequent diagnoses quite well. And you also notice on your extremity exam, this cap refill is delayed at 3 to 4 seconds. So probably the first thing that we would all do, even before sticking him for labs or an IV and all this stuff, is probably just get an x-ray. So let's get his x-ray and take a look. So this is this child's x-ray. You can see he's got what looks like a right middle, right lower lobe pneumonia. So we're gonna call him community-acquired pneumonia. So how sick is this kid? Well, we got an x-ray already. Let's talk about the workup. You probably start an IV and give him a fluid bolus. We know he's a little tachycardic. He's got a delayed cap refill. Would you get a blood culture? Yeah, I'd probably get a blood culture. The guidelines from the Infectious Disease Society of America, which came out in 2011 for community-acquired pneumonia in pediatrics, recommended a blood culture for any inpatients who have community-acquired pneumonia. It's not needed for your outpatient workup. Some subsequent research has suggested that blood cultures aren't necessary in all these kids, but I think it would be something that in this child I would go ahead and get. You definitely get a CBC for this kid. Those same guidelines recommend CBCs for all kids with severe pneumonia. I think we can probably all agree this kid has at least moderate to severe pneumonia. Would you get an inflammatory marker like a CRP or procalcitonin? You certainly don't need to get all 3, but I would definitely think about getting at least one inflammatory marker to look and see, and just as a way of monitoring this child while he's in the hospital. And RSV and flu swabs, you can certainly, some of you guys can consider for that. Sputum testing is not routinely indicated. Good luck getting the sputum anyways from a 3-year-old. I don't think if you do, you're the first one that ever has, so you can write an article in the journal about that, I'm sure. Your lab results for this child, he has a leukocytosis with a bandemia. He also has an elevated platelet count, which is very common. It's an inflammatory marker as well, and his CRP is quite elevated. At our hospital, less than 1 is normal. The normals can really range from hospital to hospital, but that's our norm. He had gotten his flu vaccine. His flu was negative. Excellent. So are you going to admit this kid, or are you going to send him home? I think we're probably all on the same page. We're going to admit this child. This child's dehydrated. He's requiring oxygen. He has increased work of breathing. So we've gotten him the bolus. We've gotten him his labs. Well, what are we going to do for his antibiotics? So we're going to base his antibiotics based on the Infectious Disease Society of America's community-acquired pneumonia guidelines, which came out in 2011. They're excellent guidelines. The link is down here at the bottom, which I included for you guys. It's free to the public, so anybody can get these guidelines and read them. But essentially, in terms of antibiotic treatment, they said that for the fully immunized child, typically we think about that as being a child who's 6 months or older, Ampicillin is your first-line IV therapy, and amoxicillin is the first-line oral therapy. And this was a real divergence for us, and for myself included. When I trained, we gave them all cephalosporins. All these kids that got admitted, cefotaxime, ceftriaxone, that's what we did, cephalosporin, that was it. But the reality was, these kids have strep pneumo. Strep pneumo is exquisitely sensitive to your penicillin antibiotics, and to be better antibiotic stewards, we went ahead and made the recommendation, this committee for ampicillin for IV therapy. You do, though, want to keep the cephalosporins in the back of your mind, so for your kid who's less than 6 months of age, who's not fully immunized, or a child that's failed 24 to 48 hours of high-dose amoxicillin as an outpatient, this is a kid that you'd really want to consider a cephalosporin for. So I'm going to give it to Dr. Colina, and she's going to talk about one of my favorite topics, bronchiolitis.
Okay. Oops. On bronchiolitis. So bronchiolitis is primarily caused by RSV, or respiratory syncytial virus. It's a single-stranded RNA virus. The clinical vignette, my patient's a 1-month-old, 21-day male, presents with a 3-day history of upper respiratory symptoms, including rhinorrhea and congestion. Since the day before, he's had difficulty breathing and raspy breath sounds. Mom gave him a half a Duoneb or albuterol neb treatment, and she states that despite treatment, he appears to be getting worse. He's more tachypnic, increased work of breathing. That being said, he has been able to breastfeed normally. He's had no fevers, no vomiting, no diarrhea, and normal number of wet diapers. Family members at home, again, have a URI symptoms. He has no significant past medical history. He was a full-term vaginal delivery infant without complications. Birth weight was 6 pounds, 13 ounces, takes no meds, no allergies. Immunizations are up to date, no tobacco exposure, lives with parents and siblings with URI symptoms. So at presentation, his temp is 99.3, his heart rate is 163, respiratory rate of 68, 100% on 2 liters nasal cannula. Now, he's awake and alert, but he's in obvious, significant respiratory distress. He's tachypnic, he has subcostal and supraclavicular retractions, nasal flaring, he's tachypnic, he's grunting. But he's normal cephalic with moist mucous membranes. He has clear nasal rhinorrhea. He has wheezes are present, but no rales. He's tachycardic, but no murmurs, rubs, or gallops, and the rest of his exam is unremarkable. So as I told you, RSV is the most common cause of bronchiolitis and pneumonia in children. It accounts for 18% of our ED visits and 20% of our pediatric under 5 admissions for respiratory causes. There is a known seasonal outbreak. It's primarily a winter disease. It begins in November, peaks in January and February, and then peters out by the end of May. Almost every child by the age of 2 has been exposed, and the children who become severely ill are typically under 6 months of age. Males are predominantly more affected than females with respect to severe bronchiolitis. Mild to moderate cases are equally distributed between boys and girls. There is an annual admission rate of 126,000 per year, with 5% of those children requiring mechanical ventilation. And worldwide, there's about a 5% mortality rate. So other common causes of bronchiolitis include metapneumovirus, influenza virus, parainfluenza virus, rhinovirus, adeno-coronavirus. And what it is it's an infection of the bronchioles, which leads to inflammation and swelling of the bronchioles and increased secretion of mucus. This causes airflow disruption. It becomes harder for airflow to occur. So the bronchioles are down in the lower lung fields, and there's your inflammation and increase of secretions. So it produces significant morbidity and mortality in high-risk infants, and high-risk infants are characterized by prematurity, immunocompromised, congenital heart and lung disease. Again, just like asthma, it's on a continuum from mild, moderate to severe. Milder cases will have some clear rhinorrhea, tachypnea, maybe some sneezing, coughing. These are in very little children. But once you get into the point where you're noticing nasal flaring, grunting, head bobbing, cyanosis, that's a more significant case, and that those children will end up, or should be hospitalized. So there was the American Academy of Pediatrics in 2014 produced or revised their clinical practice guidelines in a paper that was published in Pediatrics called The Diagnosis, Management, and Prevention of Bronchiolitis. And for your typical bronchiolitic that's not toxic appearing, the workup and the assessment is very easy. The history diagnosis is based on history and physical. They recommend no labs, no chest x-ray, no continuous pulse ox, no chest physiotherapy, no assessment for serious bacterial infections. The only recommendation that they did support was high-flow nasal cannula. Based on a study out of Australia, it appears that high-flow nasal cannula reduces the need for intubation. So as I said, you're not to get an x-ray, but if you were to, characteristic x-rays of bronchiolitis are bilateral perihilar fullness. There's another study. This was published in JAMA 2014, and it looked at the effects of oximetry on hospitalization in bronchiolitis. And this study was done because the annual cost is in excess of $1 billion for care, morbidity, mortality, and hospitalization. And they noticed that the rate of hospitalization for bronchiolitis increased from about 13 to 30 per thousand between 1980 and 2000. So they took it upon themselves to look at what's happening here in terms of bronchiolitis. And what they did was they assessed 1,800 patients. What they wanted to look at is how does oximetry affect a physician's decision to admit a pediatric patient or any kind of patient for that matter. So what they did was they looked at 1,800 patients, and of that they excluded most of them. But it's still a valid study in my opinion. They took 200 patients and they randomized them, and one set of patients, 100 of them, the physician saw the true oximetry reading on their pulse ox. The other 100, their pulse ox reading was 3 points higher than its true reading. And so then they said, well, what's our outcome? Our outcome is going to be hospitalization within the next 72 hours versus ongoing in-hospital treatment for 6 hours, which I interpreted as ED care. And what they found in the patients with the true oximetry group, 41% of those patients were admitted, okay? In the patients where the oximetry group was altered to be 3 points higher than what it truly was, only 25% of those patients were admitted. So their take-home message was, actually oxygen saturation should not, and it should not be the only factor or the deciding factor about whether you admit a patient or not. And what you really need to be doing is looking at the degree of respiratory distress, hydration status, mental status. That's what you should use to whether you decide to admit a child to the hospital with bronchiolitis. So take-home message is no albuterol, no steroids, no antibiotics. You can try a trial of breathing treatment if you hear wheezing. High-flow nasal cannula. My vignette, that was a real case I had. It was we used high-flow nasal cannula. No antibiotics, no breathing treatments. Patient did fine. Was hospitalized for a couple days, but did great. Bottom line: pay attention to their hydration status. Pay attention to their mental status. Look at the clinical appearance.
Thank you. And Dr. Colina is absolutely right about that last case. We shared that case, and she managed that child so well in the ER that he looked great by the time I got down there to see him. He was on 4 liters high-flow nasal cannula. He went up to 6 and went home 4 or 5 days later and did fabulously. So we're so happy that was a win-win. So our last case is fever without a source. This is a little 3-month-old that you see in your office. He comes in with 3 days of fever. Every day he's had fever several times a day, up to 102 degrees Fahrenheit. And he doesn't have any other symptoms. He otherwise is doing great, but mom's concerned about this fever. Why does this kid keep having this fever? Everyone else is well at home. He's been eating well. He has a normal number of wet diapers. So otherwise, his past history is really unremarkable. You know, he got his immunizations through his 2-month shots. There's nobody else sick. Everybody else is, there's no childhood illnesses in the family. They haven't been, they've just been recently in Los Angeles to see family, but otherwise very unexciting history. And on physical exam, it's also very unexciting. You don't find any source for this infection. It doesn't seem to be viral. He doesn't have any congestion or runny nose. He doesn't have any physical exam findings. You don't find a otitis that's hiding in there. Everything looks great, so you're wondering, well, what the heck are we gonna do? What's our next step in this child who's 3 months old, who has a fever for the last several days at home, but doesn't have an apparent source? So are you gonna poke him? Are you gonna get labs? Are you gonna poke his back? Does he need to come to the hospital? Do you need to call Deb Colina in the ER to say you're sending her a 3-month-old with a fever? What's our next step? Well, our next step that, as pediatricians, I think that we would all agree upon is that we need to get a catheterized urine specimen. So this is the most likely source for of infection for a fever that doesn't appear to have a source in a child that's of this age, that's 3 months old. So you do a catheterized urine analysis in your office, and you find that the child has large Luke esterase, and when you send it to the lab, they come back with the information that he has white blood cells that are too numerous to count. He has positive nitrites, he does have a small amount of blood, and positive bacteria. So now you know, you got a source for your infection, you're good to go, but you're wondering, this kid's 3 months old, he has a fever, he looks great. Do I need to stick him? Do I need to do something more for this kid? Do I need to send him in to get labs? A recent study from Hospital Pediatrics in 2015 showed that the prevalence of concurrent bacteremia with UTI was really, really low, at about 8%. However, what they really found overall is when they looked at these kids that had had bacteremia or not in the context of a UTI, some of them had gotten long, long courses of parenteral antibiotics. Some had gotten 0 days of parenteral antibiotics, and yet they both did well, none of them getting rehospitalized with the same bug, which really suggests that a long IV course in hospitalization isn't necessary for these kids, even in the context of bacteremia. But this is a kid that we don't even need to stick, which is even better. So for your well-appearing child with a fever without a source, you can really just start with a catheterized urine specimen. UTI risk factors include obviously a history of urinary tract infection, a circumcised male less than 6 months, an uncircumcised male less than 12 months, or females less than 2 years of age. You want to make sure you're sending for that urine analysis, urine microscopy, and urine culture. And if you have a well-appearing kid who has a positive UA, you don't need to hospitalize them. You can start antibiotics based on your local resistance patterns. And in our area, that's likely F.A.C.E.P. So like so many of the topics we talked about today, these are also, my recommendations are based on guidelines that came from 2011 as well, a very popular year for guidelines, from an AAP subcommittee that included experts in many fields of pediatrics. And they apply to children 2 to 24 months of age, although I will say that people are using them for the younger children as well. And there are of interest going to be, hopefully this summer, they're supposed to come out last fall, but hopefully this summer there are going to be guidelines on fever in the infant. So stay tuned for those of you who take care of little ones with fevers. As with any guideline that we've discussed here today or that you ever read, these are really meant to assist your clinical decision making. They're not there to replace your clinical judgment. But what do the guidelines say for this? They say that oral and IV antibiotics are equally efficacious for the treatment of UTI. You don't necessarily need an IV antibiotics. Duration of treatment should be 7 to 14 days. And to establish a diagnosis of UTI, you really need 2 things. One, you need a positive urine analysis, which means pyuria and or positive nitrates, Luke esterase. And you need at least 50,000 colonizing forming units on a culture from a catheterized specimen or a suprapubic specimen. And so you really need both of those components because children can have what they call asymptomatic bacteria. They have bacteria in their urine, but they don't have any other symptoms and they don't have any evidence of pyuria or infection. If you treat these kids who will have a positive urine culture but not a positive urine analysis, you're just creating more and more resistant organisms. So what workup do we need to do down the line? Well, when I was a resident and when I first started practicing, we would always do a test to cure. We would want to make sure in a couple days that this urinary tract infection had cleared, and so we would catheterize this kid again. You don't have to do that. If your child's afebrile, they're looking good, you can say you've cured this urinary tract infection clinically. Do you need to get a renal ultrasound? Yes, the guidelines from 2011 recommend for first-time febrile UTIs that all those children get a renal ultrasound. But we used to also do a VCUG. And we did that certainly up until 2011 for all intents and purposes, although the Europeans and most of the societies in Asia and Australia had stopped doing this years ago. But now the guidelines from 2011 say that for a first-time febrile UTI, you no longer need to get a VCUG, which is great. Less radiation exposure. Sometimes these kids required sedation. What they had found is that recurrent UTIs at most cause about 0.3% of chronic kidney disease. So in the absence of structural kidney abnormalities. So in this kid who doesn't have structural kidney abnormalities, meaning his renal ultrasound is normal, negative, this is why you don't need to get the VCUG, because the long-term reason that we want to know this is because we want to prevent any chronic kidney disease. So there's no reason to get the VCUG in that initial child with a first-time febrile UTI. Do you need to prophylaxis child if he's got a positive positive renal ultrasound or a positive VCUG? I will be honest with you, this is controversial. It depends upon who you ask. Pediatric hospitalists would say no, and pediatric urologists would say yes. And we're using the same data to give our answers, so you'll love that. So the RIVER trial, which came out in the New England Journal in 2014, showed that renal scarring did not differ between children who had received prophylaxis, who had reflux, and those who had not. But they did find that there was much more resistant bacteria in the group that had been prophylaxed at 63% versus in the group that had not at 19%. So what the urologists will tell you, and they're right because they're using the same data we are, they'll tell you that prophylaxis did decrease the urinary tract infection recurrence rate by about 50%. So they're right, it did. But we will tell you, using those same numbers, that to prevent one UTI, a child needs to receive 6,570 days of prophylaxis to prevent one 7 to 14-day treatment course for urinary tract infection. I don't know, that's 18 years versus 7 to 14 days of antibiotics. I think I might go with the latter. We certainly appreciate your time. We thank you all for your interest in this, and we have a couple of minutes for questions, it looks like.
Questions for Dr. Marek and Colina?
What is the mechanism of the magnesium?
I knew that question was coming.
She did.
So magnesium inhibits smooth muscle contraction. It inhibits the mast cell release of histamine, and it also inhibits acetylcholine release. And acetylcholine is the primary parasympathetic neurotransmitter in the bronchioles that lead to constriction and excess mucus production.
Hi.
Hi.
No.
When I was a resident, people were looking at hypertonic saline for bronchiolitis.
Yes.
And at that time, we still didn't know. Do we know the answer?
Yes, I think it is a recommendation now. It does work. It's thought to work, right, Dr.?
So what they've shown is that if you have children that have an average length of stay for bronchiolitis, that's more than 3 days, which is not our patient population at Memorial. Our kids are usually in and out in a day or two. Tuck can tell you, Deb, Colina can tell you that too. That if you use it continuously over that first day, you reduce length of stay by about a half a day, but it's only in this very select population of kids that are going to be there for longer than 3 days. So, yeah, I think, we've tried albuterol, we've tried racemic epinephrine, we're trying hypertonic saline, we've tried regular saline too. We're pretty much willing to try anything because we don't have anything. And so, and really none of them have really shown to have a great effect on kids with bronchiolitis. It's simply time.
Got time for one more question?
Right here. As far as I know, I've never done a cath UA on a pediatric patient, so should, in a clinic setting, I don't even know if my nurse MAs do it, so do we send them to the ER? We need to learn how to do this? What do you say?
It's certainly something that you could learn how to do in your office. Our pediatric nurses have gone out to the urgent cares and various other sites before, and I can certainly talk to you about maybe having one of them come out there and show you how to do it. You can alternatively, I didn't put this in the slide, so this is really an alternative. If you have a kid that you have a very low threshold, you could get a bag specimen. If it was negative, you could feel comfortable that it's negative. If it's positive, that kid needs a cath before you go ahead and treat. So that would be an alternative.
Thank you.
Yeah, thanks.